As John mentioned, I worked in Humana in a Medicare Advantage plan for 6 years. So during that time, I learned quite a bit about Medicare, Medicare Advantage plans, and managed care plans in general, and kind of how healthcare finance really influences the delivery of care and access to care. So I'm here today to try to share some of the information I learned along the way in hopes that it will enable you to advocate better for your clients who might have a Medicare Advantage plan. And currently, people are saying that there are either almost 50% or just over 50% of Medicare beneficiaries who are enrolled in a Medicare Advantage plan. Okay, so we're going to go over some common reasons for denials. We're going to talk about the role of utilization management and how that affects delivery of care. And we're going to talk a little bit, you'll hear some new words maybe. There's a lot of terminology that has to do with insurance and specifically Medicare. We're going to go over a lot of that. And we're also going to talk about some keywords that will help you advocate for your clients. If you do hear a term that you're not familiar with or you have a question, please hold it to the end, and we'll do that at the end of the session. I'm going to assume that a lot of you have some familiarity with Medicare, so I'm going to briefly go over some very basic things. These 3 slides could be a 2-day lecture, so I'm just going to very briefly go over just so we start out on the same page. When a person becomes eligible for Medicare, they can choose one of 2 options. They can go original Medicare, which is Part A and Part B. They can also get a Medigap plan and pay an extra premium, or a Part D plan and pay an extra premium. Or they can choose a Medicare Advantage plan, which bundles Part A, Part B, and Part D, usually Part D, not always Part D, into one premium. So they have a basic choice, option 1 or option 2. There are pros and cons to original Medicare, and there are pros and cons to Medicare Advantage plans. Today, we're going to talk about Medicare Advantage plans. So there are 6 types of Medicare Advantage plans. Most common ones are PPOs, HMOs, HMO-POS hybrid plans, and SNPs, which are usually HMOs. MSAs and fee-for-service plans are kind of dinosaurs, or you won't run into them much. That being the case, we're really going to focus on HMOs, PPOs, and HMO-POS plans. HMOs are the most limiting plans. You have to use a network of providers that have contracted with the insurance company. You have to have an in-network PCP, and you have to have referrals from the PCP for almost every service that you need. Specialists, home health, PT, any kind of therapies. PPO, you use a network of contracted providers, but you can go out of network for any service with higher cost sharing on the patient's part. You may not need a PCP at all, but you definitely don't need an in-network PCP. And generally, referrals are not required. The HMO POS POS stands for point of sale. It's a hybrid product uses a network, but for some services, you can go out of network, not all services. And you still have to have the in-network PC, but you may or may not need a referral. So those are the 3 most common types of plans that you'll find out there today. And just an FYI, there are a lot of providers that offer Medicare Advantage plans. These are private insurers. The 2 largest, or those with the most Medicare Advantage enrollees, are Humana and United Health. United Health is number 1. Medicare was enacted in 1965. In 1997, Medicare Choice plans were introduced as a way to control costs. Things were getting out of control. Legislator came in and legislated Medicare Choice as an option, figuring that private enterprise could do a better job managing costs. That hasn't really turned out to be the case, but that also is another lecture. In 2003, Medicare Choice was renamed Medicare Advantage. I don't know why. But at the same time, in the same piece of legislation, Part D plans were introduced. All of these plans are offered by private insurers, where original Medicare is run by the government. You'll hear me refer to Medicare Advantage as MA plans. The biggest thing you need to know about these plans is that they're managed care plans. That means that if someone enrolls in a Medicare Advantage plan, they're agreeing to use certain providers that have contracted with the insurance company, and they're agreeing to the terms and limits of coverage set forth by the insurance company. These strategies that control costs are called utilization management strategies, or strategies. And what we're finding is more and more these cost controlling measures are creating barriers to care and denial of care for services and products that would have been otherwise paid in a timely manner through original Medicare. You all might be familiar with this report that came out last year. The Office of Inspector General, which is a division, I don't know if it's a division or an agency, but it's part of the Health and Human Services, and they're tasked with, overseeing Medicare, CMS. They did a study. They took some denied pre-authorizations from 15 different Medicare Advantage organizations that were denied in the first week of June 2019, and they found that 13% of those denials would likely have been paid under original Medicare. They extrapolated that, and they estimated that that translated into about 85,000 denials of prior authorizations for the year 2019. So they're estimating that there are about 85,000 denials of services that Medicare beneficiaries are really entitled to that would have been paid under original Medicare. So for a lot of people, Medicare Advantage plans work well, but you can see that it can become a problem for many people because everything gets reviewed and studied under a plan. So I just wanted to talk to you a little bit about the types of denials, because if you know the types of denials, you can form a strategy on how to approach and resolve the issue. The first is process errors, which are basically clerical errors. Some piece of information was left off, coding was incorrect. The other kind is a coverage issue. Something just isn't covered or is specifically excluded from the policy. It could be it's not covered by Medicare at all or just simply by the plan. Services are not authorized or appropriate. So that refers mostly to that prior authorization. Things have to be authorized, or not appropriate means this treatment maybe wasn't approved for this health condition or this diagnosis. So it's not appropriate. The types of services that get denied often are just people go to out-of-network providers. HMO enrollees go to out-of-network providers, and the services just simply are not covered. Another area of concern is skilled nursing facilities, SNFs. If, let's say you go to a hospital, you're admitted, doctor says, oh yeah, you need to go to a SNF for rehab. Under original Medicare, you're just going to get to go to any SNF that's Medicare certified. And more than likely, Medicare is going to cover that stay to the full limit of benefits if the doctor says you need it. Under Medicare Advantage plan, the doctor is going to write the order. It's going to send it to the insurance company for approval. The nurse is going to review it and make a decision based on clinical notes, clinical information, and clinical guidelines that are standard guidelines for the industry to see if they think that it's medically necessary for you to go to a SNF. And if they do approve it and you go to the SNF, your case is going to get reviewed every 7 to 10 days or more often, and where they'll review clinical data again and make a decision again whether they still think it's medically necessary for you to be there. So under Medicare Advantage plans, you'll find that discharge or SNF stays are shorter for people. People feel that they're getting discharged too early, shorter stays than Medicare covers. This is true for acute rehab, which is an inpatient rehab. And advanced imaging is another sore spot. Advanced imaging means anything beyond an X-ray. So ultrasounds, CAT scans, MRIs, PET scans, any other radiology more intense than an X-ray is considered advanced imaging. And all of these require prior authorization. So what might happen is the physician writes an order for the imaging center submits it for approval through the MA plan, and it gets denied or partially denied. So this happens quite often, and then they have to go through an appeal process, which puts the burden on the patient and delays care. Medications often get denied. It could be that Medicare just doesn't cover the medication. It could be that it's not on the plan's drug formulary or list of covered medications. It could be that this is a brand name that was prescribed and the insurance company wants you to go and try lower, less expensive medications and prove that they don't work before they'll pay for the brand name medication. That's called step therapy. Or it could be a specialty drug. Specialty drugs are very expensive drugs. Examples would include chemotherapy drugs, drugs used to treat autoimmune diseases or degenerative diseases like multiple sclerosis. They're all subject to prior authorization reviews and oftentimes quantity limits. You can only get so much per month. Specialty drugs and other drugs are subject to those. So those are the types of things that can happen, barriers that could happen to your clients when they are trying to seek and get the care that they need. And now they have to appeal it, and it's a delay in care. As I mentioned, some of the reasons would be lack of prior authorization, or there was no referral. The person went to an out-of-network provider. There was a specific exclusion in the policy, or the insurance company didn't think the product or service was medically necessary. Under Medicare, well, Medicare doesn't pay for anything that isn't considered medically necessary. So in the broadest sense, there has to be an order from the doctor. If there's no order from an authorized provider, it's just not medically necessary in Medicare's view. So, but as long as you have a doctor's order under original Medicare, they'll pay for it. Usually, I mean, most often. Rarely wouldn't they. But under a Medicare Advantage plan, you might have the doctor's order, but it also has to go through utilization management. The insurance company, again, will decide whether they agree that this is really medically necessary. So again, barriers to care, delays in care. Some other reasons for denials include the coding errors or clerical errors, which we call process errors. Claim was filed too late, or there was an expired claim, or the treatment wasn't appropriate for the condition or diagnosis, or the treatment was investigational or experimental. So these are other reasons that you'll see prior authorizations or claims being denied. I just want to point out there's a difference between a rejected claim and a denied claim. So if it's a clerical error, for instance, something's missing, they didn't include some information, that claim will get rejected as unprocessable. So when that happens, you're not going to appeal that claim because it hasn't really been denied. It's just been rejected. So what you have to do in that case is reach out to the provider and have them correct the error. Usually it's a coding error or just some information was omitted from the claim. And so you'll have to collaborate as an advocate on behalf of your patient to get that corrected, and then the office would resubmit the claim. So it's not a denial, it's not an appeal. The key to everything really is the evidence of coverage. That's basically the policy. It includes everything that's covered under the health plan, and it specifies things that are excluded from the health plan. It tells you what your out-of-pocket costs are going to be, your deductible, your copays, your coinsurance, your out-of-pocket maximum. It'll tell you what services need to be pre-authorized and which services need referrals. And it will tell you the limits of coverage. You know, for instance, you only get so many, 35 or whatever, therapy sessions. You know, it'll tell you that in the policy. So everything you need to know, exclusions, limits of coverage, and the rules that you need to follow to get your services covered. This is supposed to be sent out to Medicare enrollees every year. The new evidence of coverage is supposed to come out in September for the following year's plan. But sometimes that doesn't happen. I've never had a client say they actually did receive that. But you can go online to the patient's portal on the insurance company's website, and you can usually access it there. If you can't access it there, you can call customer service and request a copy. Of course, when I say you, I mean your client can do that unless you're already added as an authorized representative through the insurance company. Utilization management is what we call these cost-saving strategies that insurance companies use. And the original idea of MA plans, as I mentioned, was to cut costs, reduce fraud and waste, which is a good idea, right? I don't think anybody is opposed to, you know, cutting down fraud and waste, but things have gotten a little bit out of hand. So the rule was Medicare Advantage plans have to cover everything Medicare covers. And they can cover additional things, but they have to cover what original Medicare Part A and Part D covered, Part B. But they gave them a little leeway, and they said, you have to cover this, but, you know, you can make up some rules to try to cut costs. And so that's what utilization management is. In this diagram, you can see that really every player in the healthcare field that provides a product or service to a patient plays the game. They're all submitting up to the Medicare Advantage plan for approval. The insurance companies at the top, you know, making the decision whether this is an approved item or not. So I just want to point out to you that the patient is not in this picture. In this whole process, the patient is really powerless. They can't initiate a service. It has to be ordered by a provider. They don't say, yeah, I really need this. They have no say in it. It's between the providers and the insurance company. So there are 3 types of utilization management. Prospective is the review that happens before the services are provided. So that's your predetermination of benefits. That's your prior authorization, pre-certification. There are so many names, you know, for pre-certification, prior authorization are essentially the same thing. So that would be done if also just any kind of service like imaging or any of those other things we discussed, but also if you're going in the hospital would submit ahead of your planned admission predetermination of benefits, and department would do a prospective review to see what they'll approve. Concurrent review happens while services are being provided. So the most common example of this is when a person's in the hospital. A person went to the ER, was admitted, it wasn't planned, and the hospital now has this person admitted. Now they're submitting to the insurance company for approval of the hospital stay. So it's happening while services are being provided. And retrospective, of course, is after services are provided. This happens a lot when, let's say you go to the ER, you're admitted on a Friday, you're discharged on a Sunday. The department doesn't work weekends, they come in on Monday, and all these requests from hospitals are sitting there and waiting for the review. So they review them retrospectively after the services were provided. So when you're advocating for your clients, I think it's really important to understand some of the structure of the insurance company that you're trying to navigate. They're very complex and they're designed that way on purpose. I've put these things in silos because that's how insurance companies are structured. They keep people siloed. Different departments are siloed. Different processes are siloed. And there's not a lot of cross-silo communication. So just in the UM department alone, there'll be one group that is reviewing acute care, inpatient hospitalization requests for coverage. There'll be another group that's doing post-acute, like SNF admission reviews. And there'll be another division that's doing inpatient behavioral health services reviews. That's the inpatient services. They're all separate departments. Outpatient services, you have one group that does durable medical equipment and supplies, prosthetics, orthotics. Another one that's doing home health service reviews and approvals. Another one that's doing labs, imaging. And they're all separate departments. They're not talking to each other. Or the reviews might be done by procedure, cardiac, radiology, orthopedic. Those are typical specialties that reviews are broken down into. And then there's pharmacy services, which is usually an entirely different even unit of the insurance company. And within that, you have clinical pharmacy review. They're doing the prior authorization requests, tier exception requests, that sort of thing for what I consider regular medicines. And then there's the specialty pharmacy review that's doing the prior authorizations and reviews for the specialty medications, which are those high-cost drugs. And then some insurance companies might even have another group that does the approvals for injectable medications. So you see, it's very fragmented, and these departments oftentimes can't even talk to each other. So when you call customer service on the behalf of your client, you're going to talk to a customer service representative, and that representative has a limited job scope, can only look up, have access to, or help you in a very limited way. Even if you know this problem is a problem in the UM department, you need to find out the status, or you know that they need more information, but you don't know what information, that customer service representative frontline isn't going to be able to help you because they're not going to be even able to see where that is and what's missing. They can only really see if it's pending, approved, or denied. And to make it even more complicated, a lot of these UM departments are outsourced to third parties so that they have separate computer systems that don't talk to the insurance company's system. So, you're just not able to get the information that you need to help the client. So it's helpful if you know, as an advocate, that you're going to come up, encounter these barriers. Then you can ask the customer service rep, well, can you contact the UM reviewer to find out the status? Do I need more information? What's the holdup? But then the customer service rep might not be authorized to call the UM reviewer, and it can only do it through chat or email. This is really like how it works because you can't talk to people. So there's a delay in response because the UM reviewer's busy doing something else. They don't answer the email. They don't answer the chat. So you have to follow up on another call. Because a lot of customer service representatives are not even authorized to make an outbound call to follow up with you. So these are all, I think, put in place deliberately. So you just have to know when you're calling that you're going to come across these obstacles, and all of these roles have performance metrics that they have to meet. So they can't afford to spend a lot of time with you to do a deep dive into your problem because they have to deal with X number of calls a day. They have to fill out a certain form, this many forms per day. They have to submit documentation on this many clients today. So if they spend a lot of time with you, they're not going to meet their quotas, and that's going to affect their employment status. So you might find that you're going to get transferred. Oh, I can't help you. I don't know. Let me send you to this department. And somebody there is going to talk to you for 5 minutes and transfer you to another department. But It's rare that you can find somebody who's really driven, self-driven, to really do that deep dive to help you get to the bottom of your problem. And then there's internal peer-to-peer reviews, another barrier to care. Again, designed to save costs and reduce fraud and waste. But what happens is care is delayed and denied when it otherwise would have been covered under original Medicare. So internal peer-to-peer review occurs when, let's say, your doctor orders you a service. It could be something as simple as a CT scan. Usually it happens in more complex cases, but I did talk to an orthopedic surgeon who tells me he gets peer-to-peer reviews for CT scans very routinely. Oftentimes it's a more complicated, hospital admission. The UM nurse doesn't have enough information or enough knowledge to make a determination, and then she'll forward it to the medical director to review. And oftentimes the medical director will schedule a call with the ordering doctor to further discuss the case, get any questions answered, see if they can get more information to be able to make a decision. So what happens here is the person who is going to get the service has a delay in care because this is another obstacle. And so that care is delayed, but it also takes the doctor away from all the patients that he could otherwise be seeing, but he has to stop at the scheduled time to make this call with the medical director of the insurance company. So it impacts the care of all his patients, really. External peer-to-peer review is more when you've had a denial and you appeal it through the insurance company and they uphold the denial. You can file an appeal through a third-party QIO, Quality Improvement Organization, that is contracted with Medicare to represent beneficiaries, Medicare beneficiaries. Levanta and KeyPro are two of those companies that they're contracted through CMS, and they represent beneficiaries in different states. So just, know that everything needs a referral. So just help your client get the referral, follow up on the referral, track down the referral, make sure the office actually ordered it, make sure the specialist got it, and make sure it's all happening, because a lot of these things fall through the cracks. Almost every service requires a prior authorization. So always check to see if it's required and get it. Almost always required. And I told you before about medical necessity. There has to be a doctor's order for it, number one, or it will not be covered. And then otherwise, the reviewers rely on clinical documentation and coding. And a lot of times the documentation is not sufficient or the coding is incorrect. These are just some of the services that often the most commonly requested prior authorizations. It's a short list, but it really covers a lot of services. I just want to point out, especially with the HMO, the role of the PCP is really, really important. The PCP is taking care of the patient, they're writing orders, they're prescribing medications, they are making referrals to specialists, they're doing prior authorization requests. So it's really important that the PCP is responsive and the patient feels comfortable talking about their needs and concerns with the PCP. And it's really important that PCP's office staff is competent, because those are the people who carry out these tasks. And if your client doesn't have a good relationship with their PCP, or the PCP office staff is not doing a good job, you need to help them get a new PCP, which they can do at any time. They just need to inform the insurance company before the appointment. You might be dealing with a variety of people at a doctor's office, a home health agency. You might need to talk to the surgical scheduler or the referral specialist or the office manager, and sometimes there are case managers. And at home health agency, it's going to be the intake specialist or the scheduler. So you need to know who you need to talk to get resolution for your client when something doesn't go right. Coding's critical. And to make things even more complicated, many provider offices outsource coding and billing. So when you call with a problem, You'll call billing, they'll send you back to the doctor's office. The doctor says, I can't help you with that. Well, you need to find the coder. The coder probably didn't do something right, or the doctor or provider did not document adequately so that the coder could pull out the right coding. I know I only have 5 minutes, so I'll skip this slide. I talked about HMOs. You need to use a network or it's never covered except in a couple of situations. Emergency services at an ER urgent care, if a patient believes that there's a medical emergency, and the key is the patient believes, any reasonable person would believe this is an emergency. It doesn't mean that a clinician would consider this emergency. If you have to go to temporary out-of-network dialysis, that would be covered as in-network. And if you get a network exception to go out of network, that could be covered. I have a lot more to go into. I'm not going to get to it, but I did create a Medicare Advantage guide as a supplement to this presentation that contains more details. And also, I put together a glossary of terms that I think every advocate should know if they're dealing with insurance at all, and specifically Medicare. So you can download that. I've got a QR code here, and you can scan it in and make a request for that guide if you'd like, and I will get that to you after the conference. I wanted to talk a little bit about the terminology and to let you know that there's a lot of terminology out there that's it's not standardized. Certain things, it's not specific, or this word is very vague. Like if you say, oh, my patient needs to go to rehab, well, what does that mean? Does that mean inpatient rehab, or does that mean outpatient rehab? And if it's inpatient rehab, well, do you mean acute rehab, or do you mean skilled nursing facility? So one of the things that I want to make sure and emphasize is that you really need to know the terminology, and you need to be specific in your terminology when you're advocating for your client. And even sometimes there's just no agreement on the meaning of words, and utilization management and utilization review, sometimes those terms are used interchangeably. People think they mean the same thing, but even when you go to some credible sources and they try to explain the difference between the two terms, they have completely different definitions from each other. So there's just a lot of times there's no agreement on what the term means. Here's the QR code, and I'll show it again on my last slide as well. In the guide, I can't do it now, but I've got some quick tips basically about Medicare, things you should really make sure you know. Some things you should know about Medicare Advantage plans specifically, and these are all in the guide too. And we're not talking about appeals here, but I do include some basic things you should know about appeals, including pharmacy appeals. And there's the QR code again. So I think I skipped some slides, but I think I made the timeline. So does that